You are listening to the Sanity Drive podcast.
Hello, everyone, and welcome to another interesting episode of Sanity Drive podcast, where we make neuroscience relatable, real, and actually useful for our everyday living. My name is Nosarime Abe, and I will be hosting this session. And today, we will be going deep into a particular topic that I once had on my YouTube short, and there were a lot of requests to go deeper into the neuroscience of it. And sometimes the most powerful conversation that's happened usually happen when we're able to connect the dots, and some of these dots may seem completely unrelatable. And today we'll be talking about something that affects millions of people, especially our men worldwide. Yet we don't want to discuss it. We are careful to talk about it in the public and even in the medical space. And surprisingly, it has its root in some neurological connections, obsessive compulsive tendencies. And today we'll be looking at the connection between obsessive compulsive tendencies and our sexual performance. We'll be focusing on men, and with time we'll also touch on how it affects female sexual dependencies. And to discuss this with me, I have someone that is very special. It's great that we have someone who had experience in this field to talk about this. He's a neuropsychiatrist, and he's been studying some patterns in the brain for years. And I'm sure he'll be able to make us understand how this pattern relates obsessive compulsive disorder and sexual dysfunction, especially in male. And when I say OCD, in case you heard me or Dr. Benuga talk, say OCD, he meant obsessive compulsive disorder or obsessive compulsive tendencies. So I'll go straight in, and before we jump into the session for today, I'll just allow Dr. Boyiga to briefly introduce himself, so we can jump right into the question session. Dr. Boyiga, you have the floor.
Okay, thank you so much. And I am a psychiatrist, a neuropsychiatrist, and with interest in almost every field in psychiatry. In our postings, we cover everything. So I do adult psychiatry, I do child psychiatry, I do forensic psychiatry. I also do addiction psychiatry. And what we're dealing with is a field of community psychiatry largely, and also something of interest, something I've been studying for over 4 years. And it's good to be here to share my view on the subject we're discussing. Thank you.
Thank you again, Dr. Benuga, spot on. So I'll jump right into the question. My first question to you is concerning these two major keywords that we're looking at, and that is OCD and premature ejaculation. And I want you to first take us through the science, because somehow I love science, and I want you to just briefly sandwich us with some of the science of what is happening in the brain when someone with OCD tendencies tend to experience sexual dysfunction, and why are these two seemingly different issues? OCD is on a different part, and we have premature ejaculation relates with sexual performance. How do they connect neurologically?
Okay, thank you so much. We will need to zoom into the neuronal level to understand this subject we're dealing with. And at the neuronal level, there are two things largely that are being shared: the neuronal circuits and also the chemicals that are responsible for communication in the brain. They are called neurotransmitters. You understand? So for us to go deeper into understanding the core occurrence of these conditions, we have to understand that when someone has OCD at the neuronal level, there are some lobes in the brain. One of them is called the orbitofrontal lobe. That part of the brain it gets hyperactivated, and that leads to errors in monitoring the things that someone is doing. The other part of the brain that is involved is called the anterior cingulate cortex. In that anterior cingulate cortex, there is hyperactivity again that leads to conflicts in dictating what one wants to do, and largely leading to anxiety. Now, the same OCD, there is a part of the brain that is called the caudate nucleus. The caudate nucleus is responsible for filtering what our thoughts are, in understanding how we will respond to those thoughts. Now, there's ineffectiveness of that caudate nucleus in OCD. Do we understand? When I say OCD, I mean obsessive compulsive disorder. That is at the circuit level. At the chemical level, that's the neurochemical level, that's the neurotransmitters, there's usually a balance between serotonin and dopamine. Serotonin is a neurotransmitter that plays a crucial role in these illnesses we're discussing. So when somebody has obsessive compulsive disorder, there are low levels of serotonin. That serotonin is responsible for regulating these intrusive thoughts that one has. When I say intrusive thoughts, these thoughts are coming, you can't regulate them, and sometimes you're forced to work with them. And you cannot have that peace of mind until that circle of it until you go to do it. So in OCD, the level of this serotonin is low. And then there's also excess of dopamine. I said there has to be a balance of serotonin and dopamine for one to function effectively. So there is excess dopamine at the striatal level. That is responsible for one having the compulsive components of the illness. So there is low serotonin, there's high dopamine, and then there are also some circuit problems happening at the same time. And that is for OCD. Now, if you come to premature ejaculation, the body has a balance. These neurotransmitters that I've just mentioned now also have a place. The neurotransmitters that have the excitatory role in one's sexual arousal, sexual drive, and ejaculation is still the dopamine. Remember, we have increase in dopamine, which is also an excitatory neurotransmitter. In OCD, serotonin is low, and serotonin is responsible for inhibiting the actions of this dopamine. So the same thing plays out. While that one is having excessive discharge, what is needed to dampen the effect of the excess discharge, which is the serotonin, is low. And that's why the person ends up having a quick ejaculation. And we also need to know that at the circuit level, we have the spinal ejaculation generation. It's actually at the lumbar segment of the spine. So when somebody has all these problems going on, he has some anxiety because of the low levels of this serotonin, the person ends up having premature ejaculation. In summary, there are things you need to take note of. When one has OCD and premature ejaculation, usually they co-occur. And their co-occurrence is because at the neuronal level, the neurotransmitters that are involved in both situations is the same. Also, the circuit that is involved in both situations is the same. So that leads to all that you have, the anxieties that come with hypervigilance, that comes from all the lobes, with the cognitive problems that the person will end up having, with the loss of control of his life, feelings, activities, and also on top of it, the problems with ejaculation. So it's important also to note that if these things are to be juxtaposed, you know that someone that has OCD is likely going to have premature ejaculation. Thank you.
Wow, thank you so much, Dr. Binuga. That science was, and the fact that you were able to break it down to a level that I think we all can really easily relate with, talking about what happens at the chemical level, neurochemical level, at the circuit level, and the OCD and the premature ejaculation has the same pathway, kind of, that affect their function. But I want to go straight into the next question, which one of the things that's stimulated this discussion is because we're having some unprecedented rate of depression among men. And I know you will agree with that globally, according to research. There is this 30% increase in the number of men who are falling into depression over the past decades. And why is this happening? There are so many research that are going into what is causing this and what could be responsible for this hike in the rate of men going into depression. How does this circle of sexual shame, because you just mentioned something around premature ejaculation, and we know this somewhat in the part of the world where I came from, we see it as a sign of weakness in the part of man, and it somewhat downplays their masculinity. So how does the cycle of sexual shame and this obsessive worry contribute to broader mental health? You are a neuropsychiatrist, and I'm sure you just mentioned you relate with community neuropsychiatry, you do different aspects of neuropsychiatry. How does it affect mental health crisis that we have today? How does it contribute to this hype that we have? Go ahead, Dr. Binuga.
Thank you, Nosa, for this real, germane, and timely question. Now, this is a subject that we always need to take more careful look into because not much is being done about it. It's not discussed much, but it's something that is staring at us. And there is an intersection between how real this is and the realities we face in practice. We need to understand three major things. This sexual shame, and then the OCD-like obsessive worries that men have as a result of not being able to in quote, have the muscularity they are supposed to be seen having, and then the distress that's come from it, many of them become depressed. So how does it happen? There are roots into this part of these problems. It is rooted largely to our cultural beliefs that what makes a man real is his ability to perform flawlessly. And this culture cuts across many cultural beliefs that masculinity equals your sexual dominance. And if you don't have sexual dominance, then you as a man, you're no longer man enough, in quote. You understand? So that feeling meets a lot of problems with the ideal and inadequacies leading to humiliations in the men and a lot of problems going on. If you come to the obsessive worries that a man has as a result of not being able to meet up with his identity as a man, men are prone to having those obsessive tendencies even more when they have OCD and when they have premature ejaculation. So putting these intrusive thoughts of in my head, I'm not able to perform as a man, puts him into becoming anxious with anxiety, leading to a vicious feedback that I'm not able to perform. Will I be ever be able to perform? And then my performance is what makes me a man. Now I'm not man enough. So these things are happening in the circle, in the person's head, repeatedly. Are you getting me? And that puts more pressure on the man. Now, the emotional fallout of this is where we have the manifestation of depression. When that circle continues repeatedly, it leads to avoidance from the man because he has to hold his identity as a man. He has to also try to make sure that his partner does not disrespect him. So instead, you have avoidance symptoms from partners. That erodes the man's self-worth and self-identity. And the next thing is the person becomes sad most of the time. You have other symptoms of depression. You understand? And repeatedly, the person loses concentration, worthlessness, helplessness, dead wishes. We have a lot of men committing suicide as a result of this. So that is how it continues to move from one stage to the other. So you have them having isolation as a result of that. Their internal weaknesses becomes more loud. So they don't want it even shown. They want to be withdrawn and be on their own self. And most times they cannot handle it. That leads to a lot of cognitive overload. You understand? A lot of pressure going on in the person's head, and it's still a circle that continues to be reinforced because the man will now start thinking of how to act. Yeah? And there are also this overlap of the neurochemistry I've already explained. Serotonin is a happy hormone, and the person has low serotonin. So that already has another background for depression. So the societal pressure on them, and the man needs to have dominance and the rest of them, and this man cannot have it and the rest of them. That puts a lot of pressure on self-confidence and self-realization, and then self-worth drops. And that's how it's linked to depression.
Wow, thank you so much. Thank you, Dr. Binuga. I like the fact that you were able to connect it with how the sexual dysfunction itself then eventually leads to this depression. And I'm happy you mentioned that part of cultural belief. And I'm sure it's not just about where I come from. Great. My next question to you, Dr. Binuga, will be, we might have some people on the call who are kind of resonating with some of the explanation you're giving those examples that you've been able to touch on while answering my last question. For someone whose sexual concern has not really been well defined, what are some of the warning signs that one might look out for to be able to say that, okay, my sexual concern could be as a result of OCD type thinking? You know, sexual concerns or sexual dysfunction might be as a result of different things can cause it. And there are different things that can lead to a dysfunction in sexual performance. So what are some of the signs that will make someone know that, okay, this sexual concern that I have might be rooted in my OCD type thinking rather than just the normal problems with maybe performance nerves or others? And I'll put it as two in one question. And the second one will be that how do people get to differentiate between an occasional worry? We all worry at one point or the other. How do we get to differentiate between an occasional worry and a pattern that needs attention, especially when it comes to this OCD, when someone's OCD tendencies need special attention? Go ahead, Dr. Binuga.
Okay, thank you once more for this question. There is something we call normal performance nerve. It's normal for a man to experience that from time to time. The anxiety in trying to please a partner, especially a new partner or somebody that you're not used to, you're not comfortable with, it can happen. But when it's carrying the OCD-like dimension, is when one has that kind of anxiety almost every day, and on everyday basis for an hour in that 24 hours. If that is in your mind and is flooding your mind for most of the time, you know, it is not normal. It's normal for one to have those anxiety from time to time. And it's only when it is normal that one has it just before the sexual experience, during the sexual experience, or after the sexual experience. But then if it's carrying the OCD dimension, it's something that takes the whole of you. The thoughts are coming and bombarding you at close intervals. They are repetitive. They are coming repetitively. They are also giving you a lot of distress. And that happens at all times, not only when the sexual activity is ongoing. It happens most of the time. So you need to consider it. In differentiating it properly, you have to consider the nature of the thoughts. Are these thoughts coming with a lot of distress for you? Are these thoughts coming at close intervals for most of the time of the day? Are these thoughts coming, you're trying to block them, but they are coming and they are getting reinforced until you act on them? If all this is happening, then you know that you're dealing most likely with OCD. If they are not happening, they are likely dealing with the normal performance nerve that a man can have. Alternatively, I've mentioned about the nature. Now I mentioned again about the frequency and persistence. Frequency and persistence leads to the man ruminating on it repeatedly. Do we understand? And then the compulsion as a component of it. It's very brief sometimes. If a man is having the nerves, he will compulse to. If that happens once in a while, it's not a problem. But if it happens repeatedly, to a point that you have the anxiety to act on it and it's affecting your peace, the level of this stress you have, if you're already feeling the severe shame, as we have mentioned, if you are feeling like, oh, instead of asking relevant questions, it looks like I will never be able to satisfy my woman. If you're already thinking to that dimension, right, then we're dealing most likely with an OCD-like condition. If you have that and it resolves because maybe at that point you don't have your confidence, then you're dealing with normal performance nerve. But then lastly, there is functional impairment. Functional impairment in the OCD. You know, OCD as an illness, I recall patients I see with OCD, they have a lot of crises. Yeah. And it's something I know we'll come to discuss maybe about how we manage OCD and the rest of it. But then there are lots of crises going on in a space where you feel you don't have peace of mind. You must continue to clean things. You must continue to act on a particular pattern. It's difficult for you to even coexist with others in peace because they may not even understand it. So when that happens repeatedly and it's now affecting your ability to function, leading you to avoid people, leading you to be socially withdrawn, then it means you're likely dealing with an OCD.
Wow, thank you again, Dr. Obinuga. And thank you for making a very clear distinction between the normal performance nerve and when there is an OCD tendency in the process or as a result of the concerns. I want us to look at the cascade effect. Is this issue, or let me call it situation, reversible? And, you know, my second question, because I'll make it a two-in-one question so you can quickly, briefly help me touch on that. I'm a woman. And, you know, we've been talking about men. Do we also have this effect in women? How does it get to affect women to just pick those two questions and help wrap up? Is it reversible? And how does it affect women? Do we have it in women too? Do we also get to be affected by these OCD tendencies?
Okay, looking at the cascade effect, it's a bidirectional cascade effect. It means OCD, through its issues, can lead to erectile dysfunction. It also means erectile dysfunction can worsen OCD. That's what I mean by bidirectional, in the sense that the thoughts leads to the pressure the man has to deliver. He is continually in a tensed state, leading his body to responding in a particular way, and most times leading to systemic breakdown and stress. That's what they call the hypothalamo-pituitary axis. It also gets affected to a point that the person's sleep and other things will be affected. Definitely, there will be sympathetic nervous system override. You understand? And when all those things is happening, the parasympathetic system gets blocked and erectile dysfunction happens. It's because of OCD. Now, OCD, on the other hand, can worsen erectile dysfunction because of the pressure the person is having. And the same thing that we discussed from the beginning is the same lobe that is overworking at all time. So there is a bidirectional cascade effect. Talking about reversibility, it's a condition that we know the cause. And there are some interventions that can be given to improve care. So there's reversibility. Yes, it's reversible. That's the word I want to use. And that should bring hope. It's reversible when you have the right care, when you have someone that understands what really is happening at the neuronal level so that they will know the degree of intervention to give. You understand? As I mentioned, it is an evidence-based discussion we are having here. And that's to say there are medications that can be given to improve this condition. There are therapeutic interventions that can be given to also improve this condition. And then there are also some mindfulness interventions that can be given to improve this intervention. And most times patients will need a three. Because if it has already happened, you need to bombard it from every angle. There are good outcomes for care, at least in our places of work. The patients have had experience with. We've had a couple of good outcomes from caring for those patients. And then the other one, a woman, coming to discuss how it affects. The manifestation is real for both men and women. Women are not exempted. But what happens is in the women, the experience is different. We are talking about erectile dysfunction because of the male. But in the female, it's completely a different manifestation. When a woman has obsessive compulsive disorder, the tendency through the same pathway we have mentioned will affect the female's sexual drive. Lead to sexual dysfunctions. And the anxiety can be there. The woman can become depressed just as a man becomes depressed. And when all those things happen, it disrupts arousal in the woman, puts pressure on the woman, makes her remain in continuous stress, affects lubrication. It can also affect orgasm and even the desire completely for a woman to be with a man. And so the same sexual dysfunction a man has that manifests as erectile dysfunction can happen in a woman. And it also have the same bidirectional cascade effect. As it's affecting the man, it's affecting the woman. As the OCD is leading to erectile dysfunction in a man, OCD can lead to sexual dysfunction in a woman. And they all have a cyclical vicious reinforcing circle.
Thank you so much, Dr. Buniga. I'm happy you were able to explain the women part too, while also touching and giving this side of hope. And that takes me to the next question. Looking at the words of hope that you just gave to us, that it can be treated both at behavioral level, maybe at mindfulness, some mindfulness activities, or even medications, or at different therapeutic intervention. I want you to, I know you're a consultant, you attend to patients in the clinic. This is a podcast. It might not, and please, everyone that might be listening, this might not be like telling you not to go see your medical healthcare provider. This is an encouragement for you to take that bold step to go see your healthcare provider. I want you, Dr. Binuga, more like you're seeing a patient now. Let's say we have a patient on the call now. What are some of the things? Maybe briefly, I know you might not be able to go deep medically, that is not permitted, but some treatment approach that you have seen that is quite promising and is able to break this cycle. If you can give some clear roadmaps, maybe how to even assess some of this intervention, who to go to, what strategies that some of them can even try at home as a male, and touch a little bit on female. I know we are not dealing with female, but touch a little bit also for female. At least I have to play women advocate on this call for a short term as well as a long term intervention, just to rewire these things. Since you have mentioned that the situation is reversible, you have the floor.
Okay, the situation is reversible, and I always like when such situations are not left for the person experiencing it, when the partner is also involved in the care, because it's a state of the mind. The pressure the person gets from it, if it comes with this mindset that somebody is helping me through with this, somebody that is directly involved, the outcome usually is better. You understand? So I would like to start by saying it should not be left to the person that is having this experience alone. You understand? And as you've mentioned, whatever I'll be saying here will not be replacement for a proper consultation and therapeutic intervention. I'll also be saying that we'll be looking at these things, even though evidence-based, we have the short-term things that can be done in the interim, and then we have the long-term thing that can be done. The short-term things that can be done are aimed at reducing the distress and the rest of them. The long-term things that can be done are aimed at rewiring the brain to have it functioning as it was supposed to from the beginning. And so it will take a longer time for one to have a proper rewiring. Some people, you're talking about a month. Some people are talking about above 12 weeks. Sometimes even far more than that, depending on how the person responds to it. So for the immediate, in the entry, we know that the anxiety has to be addressed. We know that the immediate problems have to be addressed. So what one can do at home, all those breathing exercises, they are there as natural things that can be done for one to kind of ease the person. You breathe in for 4 seconds, you hold your breath for 2 to 3 seconds, and then you exhale for like 6 seconds and hold your breath again for another 2 to 3 seconds. You do it in a relaxed mood. Or you lie on your back and then start what they call like the body scan. You scan from your hair to your toes without judgment, not blaming yourself for everything that's happened. It kind of eases your body. It kind of helps you to unwind. That has a little place before intimacy. If you have done that, the levels of these chemicals in the brain can have a little adjustment that can really help a little. You understand? And it's actually science-based. There are some things we encourage, like non-genital touch sessions before a normal arousal session. That kind of builds your confidence too. Again, it goes back to address the neurobiology. It goes back to address how this problem has started. So when you are in a relaxed mood, your body has the chance to kind of process the problem as it is. You may not do it today and have the result, but you need to persist. And that will help you to also diffuse the thoughts that I will not be able to do it. When you are doing these non-genital touching sections, you have more confidence. Your body is more relaxed. And then what initially feels like it's not possible to be done, you now discover that there is some improvement at that level. But if you're coming to
Yeah.
what you need to do in the long run, there are other things that can be done. There are some medications that can be given for the men. There are some anesthetic agents that are being used by men, like lidocaine and prilocaine, that are rubbed on the male genital organ before the sexual event goes on. But even at that, it's worthy of note. If you're using those kind of things, you must clean those lubricants before having a sexual activity, because it can lead to numbness in the woman's body. And then at the end of the day, the effects will cancel out. And so it's for you to have that experience like 10, 15 minutes before the sexual activity goes on. You use it, and then before you start the main sexual activity, you clean up before you go. But then for the long-term intervention, it's something that you need a proper therapist to guide you with, because the gold standard for obsessive compulsive disorder is to have what they call cognitive behavioral therapy with exposure and response prevention. The brain has a lot of plasticity. It has the chances to expand. It has a chance to rebuild. So when we are doing all these therapeutic interventions, you're helping the brain to rewire itself so that these problems don't continue to loop. Remember, I said it's reversible, but the reversibility depends on the timeline and what you're able to do. So in a sexual context, you have to do a gradual confrontation with performance, and then to reduce the fear that the person has, especially with exposure, checking, rehearsals, and avoiding sexual events. You are trying to do all that, but you're exposing the person gradually and graded, depending on how severe the situation is. And all hands, as I said, must be on deck. The couples, there have to be a better communication strategy. You understand? If your couple is putting more pressure on you, what kind of man are you? It's really, even the therapy may not even work. So there has to be a better communication modality for both you and your partner. There also has to be a better the word is empathy. Put yourself in the person's shoe so that you will be able to understand what the person is going through, since it's not intentional. Then, as I said, with time, there's neuroplasticity that takes place, and these changes will be appreciated. But then there are some techniques that are being used. The squeezing technique, that's it's actually a very old technique, where there's a gentle squeeze of the glans penis of the man for like 10 seconds before the man gets to climax. It kind of relaxes the person, and he has a longer time for penetration and sex. And so that can also be considered. And as a result, it will kind of over time enhance the outcome of care. Remember, I mentioned about topical applications like the creams that are there. They also have a role that they play, but it won't be done the right way. You understand? There are also thicker condoms that are used that reduces the sensation during a sexual activity. They can also help to reduce the pressure. And then you have some performance anxiety hacks, some hacks that will reduce the pressure you have in performance. There are some hacks that they say for distraction, and the rest of them, you can exercise them. So you need to bear all this in mind while you're doing all these interventions for a better outcome of care. Also remember, I mentioned that it takes time for rewiring of the brain. You're talking about for at least 4 to 12 weeks. And so you don't expect when you start today, you get results. And so you start gradually, you improve gradually, your therapist to help you through the process. The place of medication is also unique, because these medications are aimed at enhancing the reduced level of this serotonin. One group of medication is called the selective serotonin reuptake inhibitors. There are different medications that have been tried, and the outcome has been good. But then some of them are not outwardly prescribed for use in some countries. There are particular ones that are used for erectile dysfunction, like those that have other reasons why they should be having erectile dysfunction. You understand? The pulsatine mainly is the one that's being used for that purpose. That is kind of licensed for it. But we all know from practice that every other selective serotonin reuptake inhibitor, the likes of paroxetine, fluoxetine, even citalopram, they all aid to increase the availability of serotonin at the neuromuscular junction. And when they do that, you have more serotonin in action, and that will checkmate the effect of dopamine, and at least you have a better care for the patient. So that is it. But there are other medications that do not have to be. They are more commonly used, although some we don't want to encourage because of addiction and the rest of them. Some medications like tramadol at low dosage, It's known to cause premature to treat premature ejaculation, but we don't encourage that at all because of the effect it has for addiction. You understand? So one should not even try that. Then we have the phosphodiesterase 5 inhibitors. Commonly, they are being sold, and in fact, you can buy it from your chocolate store where they have been laced with the medication. You take the chocolate, it kind of enhances sexual performance. Besides all this medication and the rest, there are other exercises that one can do to also improve this condition. The pelvic floor is directly involved in this pathology. So if you do the exercises that will enhance the stability of the pelvic floor, one of them is the Kegel exercise. We do like 3 sets daily. It's known to have an effect on improving the premature ejaculation very significantly. Then you also have to find out other causes of this premature ejaculation. The person may be having this, and it may not be only because of OCD and other things that are involved. If someone has prostatitis, for instance, and is still having OCD, it now means you may be dealing with other conditions apart from just the premature ejaculation that can have as a pathology. So you have to treat that prostatitis properly, and then you have the symptoms. So it's a whole lot of so many things. There are some habits that we need to discourage in those kind of people still, like the use of pornography to feel better sometimes. And those things actually worsen the outcome of care. So then if there are other background illnesses like thyroid problems, they need to be solved, because remember, we're talking about the hypothalamus pituitary axis, and then how those axes regulate the hormones in the body. So all these things have to be considered. But we have it here on our table, and we have been discussing it, and I hope that people are better informed now, so that we can get we don't suffer in silence. And then for the men up there, let me be an advocate for you. You don't have to allow this kill you. You don't have to allow this put more pressure on you. Yes, suicide is real. On the 10th of this month will be suicide commemoration day, and men, men die more than women. Men, if they put their mind to it, they go fast. So I want to, because this affects men more, I want to encourage us men. Now, you don't have to end it all because of all this, especially that it can be managed. And as I said, there is a way out of it. Thank you.
Thank you so much, Dr. Obinuga. That was spot on, talking through the mindfulness techniques, the cognitive behavioral approaches, the medication option. And please remember, Dr. Obinuga said this should not replace the attention of your healthcare provider. Please, if you feel you're in this, you try to step out and speak to someone. This is just to encourage you that these are professionals in the field who get to interact with people who may be in your shoe, or who may be in the shoe of someone you know. Let them know there is a solution. And also, I like the fact that you touch on the couple communication strategies. And this is very important, knowing fully well that even if the person is receiving treatment, is receiving therapeutic intervention, if the couple is not cooperating, it may slow down the process. And you also gave a statement that says that what will eventually happen, or the reversibility of this situation, is dependent on the timeline, as well as the number of the action that was actually taken into place. Thank you so much, Dr. Obinuga, for this very important session that we had together. Thank you for your shared insights. Thank you for those advice, and also for playing the advocate of men. I'm also playing the advocate of women. Women know
yes,
that.
we all should have a voice.
Yeah, come off it. Thank you so much, Dr. Boniga, for shedding this much light on this very important topic, making it real, making it actionable, and also making it very relatable to our everyday life. And so to everyone that is listening, we've come to the end of this conversation, and I'm sure it resonates with you. You may also know it resonates. It's affects anyone around you. There is hope. Dr. Boniga mentioned it. Our mind, our brain can be adapted. The brain can be rewired. The pattern can be tweaked. And so just know that understanding this path is the first step. Stepping out to see maybe a healthcare provider, or voicing out and not keeping it to yourself, or thinking of committing suicide, is not the way out. He has mentioned that there is hope and there is a way to treat this thing. It might not be very short, but it can be done within a specific period of time. It's not an eternal thing. So as we continue to make mental health and neuroscience research accessible, this is someone who has been working at the front line of this part in Nigeria, and he's one neuropsychiatrist that is known for this aspect. If you need the contact of Dr. Obinuga for more questions, I'll take his permission to give it out if you want to get one-on-one with him. He's a consultant. And if you get this episode helpful to you or to anyone around you, please share it and try to subscribe so that when we have any more conversations like this, we'll be able to get a notification, and click the like button. Again, thank you so much, Dr. Obinuga, for joining me on this call within the short notice that I gave to you. Thank you again.
Thank you so much. Thank you.
With every